When we talk about diabetes, it's all about blood sugar. But what is this causal relationship of raising blood sugars and its link to cancer?
Diabetes has never been about just blood sugars.
So on one end we know cancer is on raise, on the other end diabetes is also on raise. Is the link really because of common shared risk factors or lifestyle factors, or does it really have a causal relationship itself?
Sugar is a simple term used by lay people for whatever is sweet. When you talk medically, we are talking about carbohydrates. When you're talking about Gen Z and their fad with the exercise, it needs to be combined with a healthy diet. See, there has been studies that said plant proteins are better than animal proteins.
Welcome to Oncoflix podcast. Today, our topic of discussion is diabetes and cancer. We have with us Dr. Surekha B. Shetty, consultant endocrinologist at Karnataka Diabetes Center. Welcome, ma'am.
Thank you, Dr. Rohit and Dr. Kritika, for especially initiating this discussion on a possible link between diabetes and cancer. I'm sure there is a lot to be discussed and known.
Thank you. So, when we talk about diabetes, it's all about blood sugar. But what is this causal relationship of raising blood sugars and its link to cancer?
Diabetes has never been about just blood sugars. It's a metabolic disorder that we talk about or identify by the presence of high blood glucose levels. But if you look at it, it's a very complex disease. It has multiple risk factors, different subtypes, varied clinical manifestations, varied response to therapy, and also multiple complications. When we talk about diabetes, we always talk about the risk of heart disease, kidney disease, stroke, peripheral arterial disease, and so on and so forth. And that is what most of our people with diabetes worry about also.
Mhm.
In simple terms, possibly there is no organ in the body that is not affected by diabetes.
Diabetes.
But what is less talked about, what is less discussed, is the possible link between diabetes and cancer. And I think we should talk about it because when we talk about it, we know more about how to prevent it and how to address it. Looking at the statistics, it is said that almost 8 to 18% of people with cancer have diabetes. And the risk is more for certain cancers, more so with uh, abdominal cancers like liver, pancreas, colorectum, endometrium, and also in women for breast cancer.
Breast cancer.
So what is this link, ma'am? So on one end we know cancer is on raise, on the other end diabetes is also on raise. Is the link really because of common shared risk factors or lifestyle factors, or does it really have a causal relationship itself?
Yes, when you look at the link between diabetes and cancer, it's no longer just by chance. Of course, the prevalence of diabetes is increasing, the prevalence of cancer is increasing. So, possibly that is why you're seeing more people with both diabetes and cancer. But on the other hand, it is now well understood that people with diabetes are at higher risk of cancer, and the statistics says that almost diabetes is associated with 10% more relative risk for developing cancer. Why is this happening? Possibly the first thing is shared risk factors, increasing age, gender, genetic background, physical inactivity, nutritional imbalance, smoking, alcohol, all these things are common background for development of both diabetes and cancer. Second thing, if you look at pathophysiology of diabetes, diabetes is associated with insulin resistance. That's the first step in the formation of development of diabetes. So, this insulin resistance itself is a responsible factor for many other diseases like polycystic ovarian syndrome. And now we know that even cancer could be linked to it.
Yes, absolutely.
Very interesting. You spoke about metabolic syndrome. What is metabolic syndrome? What does it consist of?
Yeah, when we talk about phenotype of people with diabetes, there are multiple other attributes they come to us with.
Mhm.
When we look at them, we identify diabetes, but they also have other comorbidities like dyslipidemia, hypertension, obesity. So, syndromic association of all these factors is defined as metabolic syndrome. So, metabolic syndrome is a pathophysiology associated with obesity. It is identified by one, hyperglycemia, second, hypertension, third, hyperdyslipidemia, and fourth one, obesity. There are various classification how you can identify metabolic syndrome, and once you identify it, when there are at least three components of metabolic syndrome, it means these people are at higher risk of developing diabetes, heart disease, stroke, fatty liver, obstructive sleep apnea, and so on and so forth. And that means these are the subcategory of people in whom we have to be more aggressive in managing their lifestyle.
So you spoke of this insulin resistance and a possible link to cancer. So with respect to cancer, we always say that the higher insulin level, which is associated with insulin resistance, could actually trigger cancer cells to grow faster. So is this the same when patients use external insulin also specifically in diabetes?
So, what is insulin resistance? It is a reduced biological response to insulin by the target cells. Which are those target cells? Liver, muscle, and the fat cell. So, in physiology, if you require higher doses of insulin to achieve the normalcy, then it is called as insulin resistance. What is the end result of insulin resistance? Body tries to compensate it by producing more insulin. That is endogenous hyperinsulinemia. Endogenous hyperinsulinemia results in various disease factors that we know of, type 2 diabetes. But on the other hand, exogenous hyperinsulinemia, which is created by us clinicians by giving in insulin, the pathophysiology of both is different, and that is something that we need to look at.
Oh, that's very interesting.
Well, when you talk about metabolic syndrome, how does it act as a soil for probably uh, propagating cancer growth?
Yeah, as I said, metabolic syndrome, again, the core pathophysiology here is related to insulin resistance. And when that happens in a genetic background and in response to various environmental factors like sedentary lifestyle, unhealthy food habits, smoking, and all these things, then we are creating a hyperinsulinemic state.
Okay.
Hyperinsulinemia is followed by hyperglycemia. And hyperglycemia means what? There is a high blood glucose and there is high insulin levels. These two in tandem act on the cells. What do? They activate the pathway of insulin and insulin like growth factor 1 pathway, which could be associated with mitogenicity and acts as a soil for cancer development.
Excellent.
So how important is it to control blood sugar levels during cancer treatment?
Yeah. Hyperglycemia, as you say, hyperglycemia means high blood glucose levels have multiple effects on the body. When somebody has high blood glucose levels, they have multiple acute symptomatology like tiredness, weight loss, fatigue, dehydration, polyuria, or polydipsia. And when they're receiving treatment for cancer, the problem is the chemotherapeutic agent or radiation or immunotherapy itself can aggravate the blood sugar levels.
Right.
So the relation is bi-way. The response to therapy in patients with cancer is poor when there is hyperglycemia. And second thing, the cancer therapy itself can cause hyperglycemia.
Right.
So we need to achieve a balance.
Yeah, we use a lot of steroids as an adjuvant to cancer treatment, and stress levels also is a little high when they go through these initial phases of treatment. All of that causes a spike in sugars.
Definitely. We see a lot of patients who had well controlled diabetes coming with hyperglycemia once the therapy is initiated. And as you said, stress plays a big role, and stress induced eating also could be one of the factors. The vomiting, loss of appetite that is associated with cancer and cancer therapy makes it worse for the patients with diabetes. And continuing oral anti-diabetic drugs also becomes difficult in them. So these are the things that needs to be addressed.
one of the most commonest used drugs is metformin.
Yes.
So, I mean, once, if at all, even in the pre-diabetic state, or if a patient is diagnosed with diabetes, the first drug is going to be metformin. We've also had studies where metformin is proven to be, it's shown to be reducing the risk of cancer growth, as well as even in cancer patients, we put it as a metronomic treatment post, the mainstream treatment. What is your thought on metformin and its impact with respect to controlling sugars and also in reducing the risk of cancer progression?
As a diabetologist, metformin is always first line therapy for me, and we love metformin. Now, if you look at the therapeutic agents used for diabetes, insulin was the first therapeutic agent discovered in 1921. It was only 30 years later, that was in 1951, that metformin was discovered.
Mhm.
Until date, it remains one of the safest, most efficacious, and cost effective agents for diabetes. The how does it act tells us something about how it has been trying to be used in cancer therapy also. It reduces hepatic glucose output,
Right.
and that way it reduces insulin levels. That means it improves insulin resistance. So, since insulin resistance is at the center of cancer also, the use of metformin in cancer idea came into the picture. And this idea became popular around 2005 when there was an observational study that said that people who are using metformin had lower cancer risk and cancer incident rates. And since then, there has been an attempt to repurpose metformin as an adjuvant therapy for cancer. But unfortunately, that observational data could not be reproduced in many of the randomized control studies. And on one of the recent studies, which was done in almost 3,700 patients with breast carcinoma on chemotherapeutic agents, metformin used as an adjuvant therapy did not show any survival benefit. So we are still a long way away from considering metformin as a adjuvant therapy for cancer treatment, but logically speaking, it's an insulin sensitizer and could change a lot of things in the insulin pathway and hence could be still an useful agent.
Excellent, ma'am. I think it's interesting.
Yeah, so we have a study ongoing, madam. So this is with respect to how fasting actually influences the cancer cells and normal cells. So we believe that in normal cells, it promotes more autophagy and mitophagy. And with respect to cancer cells, since they have defective mitochondria, when you cut down glycolysis, like how what happens in fasting, their fuel deficiency happens because they're not dependent on any other fuel as much as they do on glucose. And we did this and we have got some excellent results with respect to response itself. But we don't do this in diabetic patients because for them, maintaining a blood sugar level of less than 100 for 16 hours is really a challenge because hypoglycemia symptomatic can become dangerous also sometimes. So, what is your viewpoint? If at all we have to do this on diabetic patients, would you suggest it? What is your viewpoint on that?
Yeah, it's a tight rope to walk on because, as you rightly pointed out, uh, cancer cells are dependent on glycolysis for energy, and there is literally a state of glucose addiction. And uh, reducing the glucose intake possibly can starve these cancer cells and cause some amount of retardation in cancer growth. But again, uh, data is very limited, and to be able to apply it on a daily clinical practice would come with multiple challenges. Cutting down sugar completely is not just difficult but not practical also. So that is something difficult to achieve, especially in diabetic patients because they are on multiple drugs also.
Correct.
And to be able to eat on time and eat in moderation is what we advise them. And on the other hand, if they have to starve, it becomes a very tight rope to walk on. And fasting can induce ketosis also.
Right, right, madam. So, what is your viewpoint on this ketogenic diet, which has been propagated in diabetics as well? And they say that your the insulin levels or amount that you need can eventually get reduced because you're on a non-carbohydrate diet. So, what is your take on that?
My theory is a balanced, healthy diet is what works for everybody, including patients with diabetes.
Right.
So, any other diet that has been currently being researched or tried are based on certain hypotheses that when you undergo these diets, you're taking reducing the fat in the liver and the pancreas and hence reduce insulin resistance. But body always tries to compensate or fight back when you try to hold back calories. The data is available for low carbohydrate diet, but coming to ketogenic diet or intermittent fasting, we don't have enough data.
Right.
And there has been some studies which have looked at mortality rates in people on ketogenic diet, and it says that they have slightly increased mortality risk.
Okay.
So we still don't have a verdict on any of these dietary changes.
Right.
So, could targeting insulin resistance in a legitimate way be a cancer treatment strategy for the future?
Yeah, of late we are having a lot of discussion about targeting insulin resistance as a novel therapy for cancer management, as a part of comprehensive management. Again, a long way to go, and data is still not available on many of these things. But when you look at the most important insulin sensitizer, it is exercise. And there has been data on benefits of exercise for reducing cancer recurrence. Recently there was a paper that was out which said that best um, trick to do to prevent cancer recurrence is exercise. And exercise is the best insulin sensitizer
as well.
So, lifestyle modification is the first way of addressing insulin resistance. Either it is dietary changes or physical activity. And this comes with no added cost,
Right.
no additional side effects. On the other hand, pharmacotherapy to change insulin resistance is something that we have not been able to achieve it apart from metformin. And currently, I'm sure you all might be reading about certain drugs which are looking at insulin like growth factor 1 receptor antagonism, which could lead to anti cancer therapy. But again, the initial studies have been disappointing, I have heard. So I'm not sure where it is going to lead to.
Excellent.
So, madam, when it comes to a diabetic patient, we always ask them to cut down the sugars that they take, straight sugars like white sugar, jaggery, and all. Now, let's say a diabetic patient has cancer. Now, already they're in a state of cachexia and increase in need of calories. Would you still advocate them to cut the sugars, or would you be relaxed in that scenario?
Sugar is a simple term used by lay people for whatever is sweet.
Right.
So, when you talk medically, we are talking about carbohydrates. Carbohydrates come in two forms. One is simple carbohydrate, second one is complex carbohydrate. And we all know carbohydrates are the source of energy and almost forms 40 to 60% of our energy requirement throughout the day. When you look at carbohydrates, simple carbohydrates are the problem. So the sugars that you're talking about are simple carbohydrates. When you consume simple carbohydrates, they are digested faster, they increase the sugars faster, and also access the nidus for cancer growth. So avoid them.
Right.
The direct sugars that are available in processed food or drinks.
Right.
On the other hand, natural sugars in the form of whole grains, fruits, these are good.
Right.
So you still can continue to have them.
So we often see that in clinical scenarios, specifically when we radiate head and neck sides, there is a lot of inflammation that is ongoing, and they generally try to eat something that is easier, that will give them quick energy. And people have a tendency to cling on to ice creams, even if they're diabetic. At that point, they feel that it's easier to swallow that and it gives them energy. So if they're a diabetic, what would you advise?
Of course, in such scenarios, when people are unable to eat or they have vomiting and many other factors that restricts the food intake, we need to go on with soft liquid food, whichever is easily consumable, and possibly try to adjust the anti-diabetic therapy.
Right.
These are the patients who are mostly on insulin.
Right.
Because if the oral intake is poor, obviously oral anti-diabetic drugs will not be helpful. on insulin therapy, they will do better.
Okay.
On the other hand, a lot of nutritional advice from a registered nutritionist would also help. They have strategies on how to consume liquid or semi solid food without increasing the
sugar.
blood.
Yeah, interestingly, the point that you mentioned, which part of your meal you take that sugar spike causes less spike also if it is interplaced between meal is something that I read recently.
Exactly. Yeah, the sequence of the nutritional intake also matters. Of course, may not be relevant for people with cancer who are unable to eat well, but the current trend is eat a fiber containing vegetable first, protein, and then the carbs. That delays the absorption of carbohydrates
Okay.
and also reduces the intake of carbs.
Interesting. So we get a lot of questions from patients, when they're having a coffee or tea, they talk about artificial sweeteners. We do get artificial sweeteners. So is it recommended, or what is your take on the same?
Artificial sweeteners have always been a controversial subject, uh, especially because there was reports of safety challenges with saccharin and to some extent with aspartame.
Mhm.
Coming to use of artificial sweeteners in diabetes, one, they give non-nutritional calories, and second, they apparently uh, do not stimulate satiety center in the brain.
Mhm.
So that is why whenever they consume something containing artificial sweeteners, their hunger is still ongoing and they end up eating more.
Okay.
Second, everything that contains artificial sweetener is not zero calorie. There are other food contents that will still hold calories. So that is why it becomes important to read a nutritional label before consuming anything. Coming to use of um, artificial sweeteners in day to day life, it has to be used in very limited quantities, possibly because the safety data is not available yet.
Mhm.
And rather than aspartame, stevia is preferred, again in very limited quantities.
So when we talk of this gut microbiome, which is a leading topic now, both in cancer and many other diseases, so what kind of altered microbiome do you see in diabetics?
Yeah, we are what we eat. So, what we eat decides what our gut holds. So, when we talk about gut microbiome, it is the type of microorganisms that are harboring in our gut. There are two types of microbiomes. One is a healthy microbiome that promotes digestion and healthy metabolism in the body, and the second one, which is unhealthy, that is called as dysbiosis. So, whenever we consume unhealthy food, we are promoting dysbiosis, and this dysbiosis has been identified as a risk factor for development of various metabolic disorders including diabetes, and possibly now people are talking about link between dysbiosis and cancer also.
Right.
And how important is weight loss with respect to reducing the risk of diabetes and cancer?
Yeah, to be able to maintain a normal BMI, we need to have a sustained way of doing it.
Mhm.
There are no shortcuts. And two important lifestyle modifications that we talk about is healthy diet and physical activity. The recommendation for physical activity is at least 30 minutes of moderate intensity exercise, minimum 5 days a week. And this alone will not cause weight loss. When you're talking about Gen Z and their fad with the exercise, it needs to be combined with a healthy diet because there is a rule of 80-20. Whenever you talk of weight loss, it is 80% diet and 20% exercise.
Mhm.
Of course, once you lose weight, to be able to maintain it, exercise helps. So if somebody is thinking that I'll hit the gym, intensively exercise for 1 hour, and then eat whatever I need, please remember you're not going to lose weight. So it's a healthy lifestyle which includes both nutrition and physical activity.
Very interesting.
So what about this drug semaglutide? So there recently it's been used a lot for weight loss, and it is believed to improve insulin sensitivity also.
Semaglutide is one of the drugs that comes under the class of GLP-1 agonist, glucagon-like peptide agonist. Essentially, they act through incretin pathway. Incretin is a gut hormone that stimulates insulin production, delays gastric emptying, and reduces hunger. So, apart from bringing down blood glucose, it also causes weight loss. So, as an anti-diabetic drug, it is a very potent drug, reduces HbA1c by almost 1.5%. But the current buzz is because of its ability to cause weight loss. So, a significant weight loss has been noted with usage of GLP-1 agonist, and it can be used either as an injectable as an oral drug, and both are associated with significant weight loss. But remember, it's never a shortcut. Obesity is a chronic disease, and it's not just important to lose weight. To be able to sustain that weight loss,
Yeah.
you need to continue that drug for long term.
So it's like a steroid. You also need tapering as well. Like, for example, if you have to stop GLP-1 agonist, so you just also have to taper it if people want to stop, drugs like semaglutide.
Well, we have data to say what happens after stopping uh, semaglutide. In the span of 2 years, most of the patients gained back weight. So essentially, it's something that needs to be continued on long term. Just like any anti-diabetic therapy, uh, weight loss drug also needs to be continued for long term.
Mhm.
To stop it, weight
Correct.
comes back.
So is there a risk of, I've just read reports where, using of semaglutide also causes the risk of thyroid cancers. So there is a lot of, studies which are coming out as well, especially medullary carcinoma thyroid.
Yes,
So
this data has been an important data,
Mhm.
especially with medullary carcinoma because of the C cells. And the rat studies have shown that there is mitogenicity and increase in the number of cells. But this is not translated into any studies in humans. So, because of those studies, GLP-1 agonist as a class is avoided in any patients with history of thyroid malignancy, either in self or in the family.
Okay.
Mhm.
And how long has this semaglutide been used in diabetics?
Semaglutide, if I can say, it's a new kid on the block. Uh, Possibly last 3 to 4 years is what is it has been making a buzz. But initially, it was used as an anti-diabetic drug. Now it is more being propagated as a weight loss drug.
So, if you have to advise three people, one is a person who hasn't developed diabetes yet. Second is somebody who has developed diabetes with respect to his cancer risk. And the third one is a diabetic who already has cancer. If you have to advise each one of this scenario with respect to what changes that they can make and what they should look out for, what would it be?
Yeah, I think that's something we have to look at holistically. All the three classes of people require the same advice. That's a healthy lifestyle. If we want to stay away from metabolic diseases and cancer, it is what we eat, what physical activities we indulge, and what other drugs that we use. So, essentially, what do you mean when I say lifestyle, healthy lifestyle? It is diet which is rich in whole grains, vegetables, fruits, healthy protein, and healthy fat. See, there has been studies that said plant proteins are better than animal proteins. And when it comes to fat also, we have healthy fat and unhealthy fat. The fat that is trans fat or unsaturated fatty acids are unhealthy. Similarly, coming to vegetables, they are rich in fiber, unprocessed, and that's why they add to the health. So, consuming food that is rich in fiber, less in sugar, less in oil would be what I would recommend for anybody. Even if you don't have diabetes, it helps you in preventing diabetes.
Right.
If you have diabetes, it helps you in controlling diabetes. And possibly by controlling diabetes, it also reduces the risk of cancer. Second one is physical activity. As I previously mentioned, being physically active throughout the day and adding on Moderate intensity activity, at least 30 minutes a day, at least 5 days a week, is what keeps you going. And I tell my patients that, physical activity comes with multiple benefits. It reduces blood sugars, it reduces cholesterol, it reduces weight, it improves blood circulation, it improves bone and muscle health, and also it helps in cardiovascular health. Last but not the least, it comes free of cost.
Yeah.
So use it more. And last but not the least, if you're a diabetic, control your diabetes well, use the right drugs in the right dosage, and regularly follow up with your clinician for appropriate guidance. Another important suggestion that I would give is always look for red flags. If you have physical complaints that are not fitting in, evaluate yourself.
Very interesting. So the term right now in cancer care is immune surveillance, because there are a lot of new class of drugs called immunotherapy which has come to the fore as well. How does diabetes probably impact immune surveillance, and what impact does diabetes cause in immune surveillance, and probably could diabetes help in cancer cells evading the immune system?
Yes, as I told you, diabetes affects all the organs in the body, and immunity is one such uh, aspect that is affected by diabetes. Uncontrolled diabetes, hyperglycemia reduces our immunity, and this immune surveillance is also affected by diabetes. Unfortunately, we don't have studies that look at direct correlation between diabetes and immunosurveillance. But when you look at immunotherapy in cancer, we know that people with diabetes are associated with poorer treatment outcomes. So possibly the link lies there.
Very interesting. And talking about gut microbiome as well, again coming to the responses to immunotherapy, that could play a very, very important role, or probably like in if you have a very robust gut microbiome, probably the risk of cancer itself is on the lower side. How does diabetes impact the gut microbiome and the overall health of a person?
Yeah, as I told you previously, diabetes is a state of inflammation. So hyperglycemia is associated with various cytokines and inflammatory markers that are increased in the body. And this is directly related to the gut microbiome. The healthy microbiota translates into lower inflammatory markers in the body, and the unhealthy gut microbiome, which is called as dysbiosis, is associated with higher inflammatory markers in the body. And
Right.
this is something that has been identified in people with diabetes, and possibly again that translates into poorer response to immunotherapy.
So, to conclude, if you have to give a message to our audience, what will be a one liner?
One liner. Well, diabetes is a long term disease. It is something that you can manage, you can control with the help of healthy lifestyle and appropriate therapy. And since we're talking about link between diabetes and cancer, think of screening yourself for certain cancers that are age and gender specific. But if you're a diabetic and your sugars are not controlled, you're having weight loss, you have low hemoglobin, you have deranged liver function, you have poor appetite, then ask your clinician if you need to be screened for cancer.
Excellent, ma'am. Thanks for this wonderful, educative session on diabetes and cancer. It's been very, very
Informative.
informative. Thank
Thank
you.
you.
Thanks so
Thank you.
much.
My pleasure.